Hello everyone, welcome to today's tutoring session. I'm Dr. Simpson, and I'm excited to guide you through one of the classic Step 2 CK topics, Rheumatoid Arthritis, RA, versus Osteoarthritis, OA, Part 1. By the end of this session, you should feel more confident about how to differentiate between these two common diseases on your exam. 1. Etiology and pathophysiology. Osteoarthritis, degenerative joint disease. Think of this as the wear and tear arthritis. Over time, the cartilage in your joints breaks down due to mechanical stress. It's primarily a disease of aging and repetitive use, but it can also be triggered by joint trauma, obesity, or previous joint injuries. In OA, you'll see loss of cartilage, leading to bone-on-bone friction, causing pain and stiffness. Rheumatoid arthritis. This is an autoimmune disease. Your body's immune system mistakenly attacks the synovium, leading to chronic inflammation. RA is more of a systemic disease, which means it can affect other organs and systems, not just the joints. Important association: female sex and smoking are key risk factors. 2. Clinical features. Osteoarthritis. OA typically involves large weight-bearing joints, such as the knees, hips, and spine. It can also affect the DIP joints in the fingers. The pain in OA worsens with activity and improves with rest. Morning stiffness in OA is short-lived, usually less than 30 minutes. Joint deformity in OA includes Heberden's nodes at the DIP joints and Bouchard's nodes at the PIP joints. Degenerative joint disease. Think of this as the wear and tear arthritis. Over time, the cartilage in your joints breaks down due to mechanical stress. Rheumatoid arthritis. RA primarily involves the small joints of the hands and feet, but it can affect larger joints as well. A classic feature of RA is symmetric joint involvement, both sides of the body. Morning stiffness is a big clue here. In RA, it lasts more than an hour and improves with movement. Deformities in RA include ulnar deviation, swan neck, and boutonniere deformities. Importantly, RA does not involve the DIP joints. 3. Initial and confirmatory diagnostics. Osteoarthritis. Initial diagnosis of OA is typically clinical. Symptoms plus an X-ray of the affected joint showing joint space narrowing, subchondral sclerosis, and osteophytes will usually confirm the diagnosis. Rheumatoid arthritis. First-line tests include rheumatoid factor and anti-CCP, which are often positive in RA. Anti-CCP is more specific. On imaging, early RA might show soft tissue swelling and joint space narrowing. In more advanced cases, erosions are seen on X-rays. RA also has elevated inflammatory markers like ESR and CRP. We'll end here for now. Please join us for Part 2, the conclusion of RA versus OA. Don't forget to like, share, and subscribe to our top MD social media pages for more high-yield content and updates.